We are moving to our second lecture, and here we have a very eminent speaker with us. He's Professor Jorge Hidalgo. He's a dynamic intensivist, and he's a professor of critical care medicine, Secretary General of the World Federation of Intensive and Critical Care Medicine. He is also the head of the Intensive Care Unit and COVID-19 unit in Belize Healthcare. He's also the member of SCCM, Fundamental Critical Care Obstetrics, and he is the author of many chapters in critical care obstetrics, editor of many books. And I'm also very proud and that I have an opportunity to work with him. So welcome, Professor Jorge Hidalgo. Today, the lecture we will listen from him, that is a common approach in sepsis and novel interventions. So welcome, Professor Hidalgo.
Thank you, Dr. Alopa, for an very excellent and introduction, and also thank you, Dr. Madi, for this extraordinary effort to keep us up to date with the mega learning and engage connection. Now we have the opportunity through this mega learning to every Sunday to access to most of the most prominent lectures in the world, and also very interesting topics. And I believe the only thing that is going to happen with Mega is going to grow and grow. And I believe Dr. Madi is going to be in trouble in the future for that. But congratulations, Dr. Madi, for this extraordinary effort. And thank you, Dr. Lopa, for the introduction again. I will share my slides. And as Dr. Also mentioned, what we're trying to accomplish today is we will try to review and go through on the current management of sepsis, and also trying to spend a few slides discussing what are the new or what should be the future in the management of sepsis. And of course, despite current initiatives aimed to improve sepsis awareness and early treatment, patient outcomes still dependent upon the performance of accurate intervention, which in turn rely on practical aspects surrounding the time of presentation of patients, as well as availability of resources in many areas of the world. Effective accomplishment of the core intervention in sepsis, it demands definitely a correct evaluation and requires systems that coordinate emergency services, general wards, surgical teams, intensive care departments, pharmacy, and all to provide the optimal treatment. And as we are going to see how the treatment of sepsis has been evolved over the time. First of all, I want to mention that I don't have no conflicts of interest with these presentations, except that because Dr. Madi and all of us that we are sharing in Mega Learning are very interested in academics. And then, of course, as we already mentioned, the most important thing is that the sepsis is a syndrome which is defined as a dysregulated host response to infection leading to organ failure. And since it remains one of the leading causes of mortality worldwide, numerous drug candidates have already been tested and continue to be developed as a potential adjuvant therapies. And of course, as we know, the syndrome is a very heterogeneous, and also it causes a lot of problems in the way how the host responds to the different insults that we see in sepsis. Mean that as public health perspective, we used to assume in the past that the major people who be prone to develop sepsis, and also the most of the people that are going to be on risk to be on serious trouble for sepsis are those that have any probably a medical background, and that is true, but also As we learn about more about sepsis, and also as the knowledge that we have increases, we realize that it's a multifactorial problem, that it could be related with society, the community, at the level of community, at the level of organizational level, interpersonal or individual, and it could be related with the many other issues that we need to have into account, and not only focus on a couple aspects on that. I mean that that slide is trying to essentially exemplify the different aspects that we need to have in consideration as we are going to discuss as we evolve in the lecture. No? As we know, sepsis is a life-threatening but also a costly disease. The CDC in this report, they mentioned that more than an estimated 1.7 million people get sepsis each year in the United States alone, and about 270,000 Americans die from it. That represents that probably 1 in 3 patients who dies in a hospital will be related with sepsis. And the Agency for Healthcare Research and Quality reports that sepsis accounts for 24 billions in annual healthcare costs. I mean that those are also numbers that we need to have in consideration when we analyze that. But we have this interesting report that was published in the Lancet last year, Global, Regional, and National Sepsis Incidence and Mortality, and it basically collect data using multiple causes of death data from approximated 109 million individuals' death records to calculate mortality related to sepsis among each of them to 80,000 underlying causes of death. Mean that we found out that in this report that an estimated 48.9 million incident cases of sepsis were recorded worldwide, and 11 million sepsis-related deaths were reported, representing 19.7% of all global deaths. And age standardized sepsis incidence fell by 37%, and mortality decreased by 5.28% from 90 to 2017. Sepsis incidence and mortality varied substantially across regions, with the highest burden in sub-Saharan Africa, Oceania, South Asia, East Asia, and Southeast Asia. I mean, those are the factors that we need to consider, and in this a very interesting report about the global mortality of sepsis. I mean that the efforts has been put in trying to understand better sepsis, and I believe as this slide shows, since 1991, when we have the first mission to define sepsis, then we have a very strong effort, and especially since 2000, to trying to understand and to trying to better define sepsis. And as we usually say, each definition by definition needs to be reviewed with time to time based on the current medical evidence. And then we have the initial first sepsis definition in 1991, then the second mission to evaluate the definition in 2000. And after that, we start the efforts from the American Society of Critical Care, along with the European Society of Intensive Care, and joint efforts in order to try to have a common ground and to understand and better know about sepsis. And that's why we have the initial Surviving Sepsis campaign presented in 2004, and from then to now we have a review of the guidelines in an average of a couple of 2 to 3 years based on the current evidence. And then since 2000, by now, we have a lot of research being done and a lot of efforts put into trying to understand what we know and what are the different aspects in the understanding of sepsis. And then as this one, essentially to illustrate also how the definition has evolved based on the information at the time, meaning that we have the different concepts in 1991, then in 2001, we're trying to revisit those concepts and trying to see what things can be changed based on the evidence until we have the third sepsis definition that was presented in 2016, according with the current evidence at that point. Of course, if something is constant in medicine is the change, because what we see and what we know that is an evidence probably in the next few years will say that the things change based on the information at the moment. No? That's again to illustrate the different evolution of the sepsis definition. And then, as we know and mentioned, there are convincing mechanisms and a very robust preclinical data. Almost all drug candidates in the field of sepsis have failed to demonstrate clinical efficacy in the past 2 decades. No? And of course, accordingly to the development of new sepsis drugs has markedly decreased in the past few years. And despite of that, thanks to our better understanding on the sepsis pathophysiology and pathways, there are new promises, drug candidates that are currently being developed, as we are going to see in the coming slide, and in a state of a unique sepsis profile. As initially suspected, various phenotypes had been characterized. And of course, this has resulted in the identification of multiple targets for new drugs, together with the relevant biomarkers and better understanding of the most appropriate timing for intervention. And that is critical, timing. And as we will know, and we'll see, the timing also has been impacted the different sepsis guidelines, and I will see more of that. And within the entire sepsis drug portfolio, those targeting the immune response are probably the most promising. Of course, there are too much to see in the future. Monoclonal antibodies, also cytokine removals, also as to mention some of those, and we will to see with more detail. But again, despite of all efforts of experimental and clinical research during all this time, the ability to positively influence the course and outcomes of the syndrome, it remains limited, and evidence-based therapy still consists on the basic causal and supportive measure. I mean that SEPSIS-3 defines sepsis as we already know, life-threatening organ dysfunction caused by a dysregulated host response to infection, and septic shock essentially being a subset of sepsis with a circulatory and cellular and metabolic dysfunction associated with a higher risk of mortality. I mean that this is a slide just to summarize what we already been discussing in the last few lectures, where we essentially to summarize what we know about the pathophysiology, and just to put it in a slide, we know that we will have a pro-inflammatory response with immunosuppression, and where essentially some of the PAMs and dams are going to have an important role, and also the peripheral receptors activating the different cascade of inflammation. But this is not the objective of this lecture, and it's just to illustrate, but also to mention that most of the development that we have in the pipeline of drugs for sepsis are based on our understanding on the pathophysiology, and also in our understanding on the immunopathology of sepsis. I mean, at one more time, just to now, just to illustrate some of the difference between the different definition of sepsis 2004, and to basically put attention on that and this timing. You will see how we are evolving, and also we see that how sepsis as well as stroke and MI timing is critical, and also as our understanding of sepsis has been evolved since we in the last couple of decades, then we understand that the time as also the interventions that we are proposing are critical. Then as we see right here in details about how time is been changing in the different approaches that we have for the surviving sepsis campaign. No? I mean that all of this is basically to bring us where we are right now, and essentially the sepsis that and the evidence that we have. No? Initially, as we know, fluids is one of the critical aspects, and as we start with our initial resuscitation of sepsis, fluids plays an important role, and the actual and the present recommendation is that our initial resuscitation from sepsis that induce hypoperfusion is based on 30 ml kilogram of IV crystalloids being given in the initial in that moment in the initial 3 hours. As we always say, our patients in ICU are very dynamic, because the question is how fast or how slow we're supposed to administer the fluids. No, and it's basically on the individual basis. No, we know that crystalloids are the fluid of choice, and also we can use albumin in particular cases where we know that the patients will require some a little more amount of fluid, but also the patient have some medical background like congestive heart failure or some other medical condition that it will limit us in terms of the amount of fluid we will use. Also, we know that the use of starches and high hydroxyl starches and gelatins for intravascular volume replacement are essentially not recommended based on the possibility that these patients are going to increase those type of substances are going to increase mortality, and also is also going to favor the development of kidney failure. I mean that based on that, the eternal discussion that we will always have is right now favor crystalloid as the initial fluid of choice, and also we know that we need to do a reassessment based on the clinical examination and evaluation of available physiological parameters like the heart rate, blood pressure, the arterial oxygen saturation, the respiratory rate, the temperature, the urine output, among other variables that we can have to analyze our response, the patients, and to our intervention. And we know now that the dynamic versus to static variables are essentially more recommend to predict fluid responsiveness. I mean that as of course based on availability, And as always, we need to, in medicine, we need to have a set of goals, and in the patients with sepsis, we say we need to have our hemodynamic goals, setting the mean arterial pressure of 65 or higher as one of the most important ones. The other important aspect is essentially that as early as possible, we need to be able to take an appropriate routine microbiologic cultures and be obtained before starting antimicrobial therapy in patients that we are suspecting sepsis or septic shock. And doing so results in a not substantial delay. We need to start antimicrobials as soon as possible. And the administration of IV antimicrobials needs to be initiated as soon as possible after recognition or within 1 hour of both sepsis and septic shock. And those needs to be a broad spectrum antibiotics based on the flora that is on each individual hospital, because probably the bacteria that we are having in my hospital are not the same, and for sure it's not the same like that in any other hospital. This variability is important for us to know and to understand what is the most common germs that we've seen in our hospital based on the epidemiological data that we are collecting. And that's mean that we need to collect the cultures, and immediately after that we need to start the antimicrobial. And as we know, that is proved based on the evidence that it will improve the survival of our patients. And as soon as possible, we need to also make a decision of de-escalate, and also all efforts need to be made to try to locate a specific anatomic area or source of infection that it would probably require an emergency procedure like surgical drainage of an abscess. Mean that we need to be able to try to identify the source of the infection. The other important aspect is the use of vasopressors, and as we know, and I will see in the following slides, the timing also it will change, as well as the vasopressor of choice. Norepinephrine is by today the vasopressor of first choice, and as a second choice we can have epinephrine, and also we can add another vasopressors like vasopressin as the three of the most medications to start, as long as we of course trying to keep our hemodynamic goals and targets to trying to keep our patients in best hemodynamic status. Dopamine is as an alternative vasopressor agent to norepinephrine, but basically only on selected patients, and those patients are patients that we know that those patients are low risk for tachyarrhythmias, and that probably they have bradycardia, and those probably are some of the better choices in the case of dopamine. And of course, we know already that the low dosage of dopamine for renal protection is not recommended. I mean, that's are regarding the vasopressors. The other important absent also is that as we evolve in the understanding of sepsis, and also the different measure that we already tried, one of the things that we that were promoted is the tight glycemic control. But we know that now the recommendation is to protocolize approach to blood glucose management in ICU patients, starting with insulin doses when 2 consecutive blood glucose levels are more than 180. And this approach is essentially with the intentions to target an upper blood glucose levels and trying to maintain a glucose really, equal or less than 180. I mean, that is something that in terms of the management of the glycemic control, also the blood glucose values to be monitored in an average of 1 or 2 hours until the glucose values and insulin infusion rates are stable. Then after that, we can say, okay, we can move to every 4 hours thereafter in patients that are receiving insulin infusions. Also, the idea of enteral of the nutrition is to administer early at enteral nutrition as a preferred to parenteral nutrition in patients with sepsis, no, unless of course there are some contraindications for us to use the gastrointestinal tract, but the use of the gastrointestinal tract of enteral nutrition should be preferred before we decide to put someone in parenteral nutrition based on of individual basis and the analysis of each case in particular. In terms of mechanical ventilation, we know that we use the mechanical ventilation protective measure is the recommendation, especially if we have ERDS related with sepsis, with our targets in terms of the plateau pressure, in terms of the PEEP. I mean that those are the things that need to be analyzed. We know that before the pandemic, and of course now, most of our efforts are trying to prevent patients to be on a deep sedation as much as we can, and trying to limit and trying to have a good pain control in this group of patients. No, we need to individualize in now based on our understanding, particularly on COVID-19 cases, what patients are going to benefit of each of the armamentarium that we have when it comes to muscle relaxants and sedatives. And of course, COVID-19 is a daily knowledge. We increase our understanding day by day, and the measure of the urine output is critical to trying to intervene early and trying to detect in an early situations that patients probably will require continuous renal therapy replacement in case of patients that develop acute kidney failure. And the most important aspect also in the 2016 was the change on goal-oriented therapy versus conventional approaches, and shows that essentially in terms of mortality, it wasn't an important difference. But now, one of the things that we are illustrated on trying to say is the timing, and as we know, now in 2019, now we move to what we know the 1 hour bundle package, and then we know that the time is critical, and all those interventions that at the beginning of the Surviving Sepsis campaign was say 6 to 12 hours to 24 hours, and then move to a different timing. Now we are trying to put everything to 1 hour bundle, recognizing that time is critical. We are not going to go into the details for time, but the patients of sepsis are very dynamic, and then we know that sepsis is a medical emergency, and the earliest we can intervene is going to represent a better outcome for our patients, measure lactate, obtain the blood culture, administer broad spectrum antibiotics, start with the fluid resuscitation, and apply vasopressors in case our median arterial pressure is not being reached. And that's again to summarize that. Then the management of sepsis, as we know, are essentially based on the hemodynamic stabilization and the control of the source. However, based on our understanding on the physiopathology as well as the immunopathology of sepsis, one of the most important targets is the modulation of the host response, and then we will see in more detail. No? Then we will see that we can go either coagulation, inflammation, organ failure, or we will essentially put everything together. And that's where we know the novel therapies. We know that we have a personalized therapies based on the different phenotypes. Also, we have opportunities for immunosuppression. We have the use of nanotechnology, and of course, the increment use of the artificial intelligence. Then we see that what we have as immunotherapies, and based on the things we have been discussing, we have some intentions with adrenomodulin modulators, endotoxin inhibitors, enzyme replacement, protein C stimulant, phosphodietyl serine receptor modulator, phospholipase A2 inhibitors, TREM1 protein inhibitors, cell replacement, cytokine modulators, G protein coupled receptor agonists, and immunostimulants. And those are one of the some of the armamentarium that is being on clinical trials, and that we will know more in the near future. No? And one of the things that I will spend a few slides is on the cytokine removal therapies, that it essentially is growing as an adjunctive therapy in sepsis when all what we discussed is not working. Then as an adjunctive therapy, we are proposing this, the cytokine removal therapies has been proposed. And then as we know, those basically in the underlying blood purification technologies based on a state-of-the-art biocompatible and highly porous polymer beads that act like a tiny sponges to remove harmful substances from blood. And each of the beads is about the size of a grain of salt. And essentially, the cytokine removal absorber is composed of a highly biocompatible porous polymer beads with numerous pores on the surface. And each bed, roughly the size of a grain of salt, acts like a biocompatible and tiny sponges to remove substances from the whole blood based on process of absorption. The relevant surface for absorption is located in the inner beads. I mean that the idea is to effective elimination of cytokines on all the different inflammatory mediators that it will affect patients with sepsis. Also, it's been used in patients with rhabdomyolysis to remove myoglobin, patients with liver failure, patients that are candidates or are going for cardiac surgery, and among others, as well as lately COVID-19, to remove cytokines. Mean that removal of inflammatory mediators for these techniques are patients with sepsis in vasopelagic shock, COVID-19, especially when the patients are in the cytokine storm, inflammatory mediators for those that are going or are for cardiac surgery, emergency cardiac surgery, patient with liver failure to remove bilirubins, bile acids, ammonia, patient with rhabdomyolysis that we need to remove myoglobin, or patient with intoxications with the intention to remove toxins and drugs. I mean, those are the elements. We know that when we have a patient stable with our hemodynamic targets and patients that are unstable and evolving to shock, and then the indication for the different parameters that essentially lead us to the use of the cytosorbents. I mean, that is essentially the circuit co is proposed based on a combination with CRT technology, ECMO, CVP, hemoperfusion, among others. In conclusion, sepsis is defined as a life-threatening organ dysfunction caused by a dysregulated host response to infection characterized by sustained hyperinflammation and immune suppression. And while much progress has been made in understanding the pathogenesis of sepsis, translation of this knowledge into effective novel sepsis therapies has been unsuccessful. The aim of the future of sepsis research, it should be just that. Mean that with that, this is World Sepsis Meeting, where you can access many lectures about sepsis and also to improve the understanding. And we invite you to attend the World Congress of Intensive Care or Critical Care that is going to be an online congress leading by the Canadian Society of Critical Care. Thank you.
Thank you very much, Professor Hidalgo, for your valuable lecture. Actually, I think not only me, all the attendees and participants enjoyed, and they all are saying that it's a very excellent lecture, and they will fill up the survey after the lecture. So what I want to say that the critical care medicine is a first evolving subject, but it's relatively new branch of medicine. And with the current ongoing pandemic, I feel that it's the need and the talk of the time. And the modern day critical care revolves around many life-threatening conditions and disease, but more life-threatening conditions are, I think, half it is about the sepsis, and in different form with the presentations. So we have lots of questions with us. So I think Dr. Hidalgo will be happy to answer us. So first of all, I want to ask one question, that the why is 30 ml as starting fluids in sepsis?
Well, the 30 ml of resuscitation is as a recommendation of the initial fluid. The intention of this fixed volume of fluid is basically because it will enable us as a clinician to initiate resuscitation while we're obtaining more specific information about the patient, and also while we are awaiting for a more precise measures of hemodynamic status. Of course, there is always a question that what is the evidence? And then in recent interventional studies describe the usual practice and in the early resuscitation, and those studies are they studied the process, and they studied ARISE, that they use the 30 ml, and also the PROMISE trial. I mean that many patients probably will require more fluids than this. For this group, we advocate that further fluids be given in accordance with functional hemodynamic measurements.
So the next question is, it makes sense the use of blood purification in sepsis?
Well, as we know, there are several efforts to trying to develop treatments, and also in the therapeutic of sepsis. And one of the more evolving techniques or offering as an adjuvant therapy, because that's important. It's not the initial step that we have, but one of the adjuvant therapies that we are using is the removal of cytokines based on because other therapies are not successful, and also because that can add some help to patients of sepsis in different moments of the sepsis inflammatory cascade, based on our understanding of the pathophysiology and immunopathology as a foundation of sepsis.
Okay, that's great. But now, what is the scientific evidence in the use of blood purification?
Well, it's an important question. There are other additional treatments, including extracorporeal or so-called the blood purification techniques that have also been tried. These techniques include, among others, the hemofiltration, hemoperfusion, intermittent continuous high volume hemofiltration, plasmapheresis, or absorption. And the rationality behind or such approach is the trying to achieve that we call it an immune homeostasis.
Okay. Another question, this is from India. Dr. Shubroto asked that, I might be wrong, but I want to clear my doubt. Once I heard that after initial fluid resuscitation, if the BP doesn't improve satisfactorily, then we should add vasopressors. Now, noradrenaline is used as the first choice as per guidelines, but I heard that instead of noradrenaline, if we use vasopressin, then the outcome is better. Is there any such thing? I mean, it's not in surviving sepsis guidelines, but is it so that this type of data is coming up?
Well, the recommendation for the surviving sepsis campaign is that the recommendation is as the first vasopressor of choice is that we are going to use norepinephrine, and then as we know already, when we are on certain level of norepinephrine, then we will try to use vasopressin with the intention to reduce the dosage of norepinephrine specifically. And of course, as we know, we need to have a well-defined hemodynamic targets, and that it will allow us to, we can say, see and make adjustment to the different vasopressors, as well as to choose based on our availability.
Okay. There is another question that is basically, what are the good things to do or seek for in sepsis? Actually, I think you covered it in your lecture. I think the main thing is the initial resuscitation and managing a sepsis patient, and it's a very important, the appropriate antibiotic and the source control. So anything else that?
Yeah, as we know already, and then we mentioned the critical points is timing. As early as the earliest we can intervene, we can offer better outcomes, and then as also, and the timing is being as I'm saying, and I essentially put a lot of emphasis in the presentation, is that based on our understanding of initial sepsis campaign in 2004, and how our understanding of timing has been critical, went from 6 to 24 hours to 3 to 6 hours to 3 hours, and the latest recommendation is the 1 hour bundle, that essentially we're trying to make our patient stable in 1 hour, on the understanding that every patient is we need to individualize. Not all patients are going to be the same, as now we are trying to see that with a personal medicine, where we're trying to see how phenotyping is critical in the understanding and the way how we are going to manage. And that's say basically that probably you have a patient that it will you will put certain amount of PEEP, or you will use certain medication, and you will have another patient with a similar characteristics, but the response is different. Based on that is that we are going to is the concept of phenotyping and trying to develop a personalized medicine.
Yes, I also agree that we are getting upcoming certain novel therapies and special treatment modalities. So, which if applied we judicially and with proper timing can promise to be helpful. So, another question that I'm very interested to know that what you can tell us about the use of nanotechnology in sepsis.
Well, the application of the nanotechnology based solutions for clinicians is basically to challenge emerging and also to provide several opportunities, especially in diagnosis of the management of the critical ill. And essentially, as we know, nanotechnology shows potential in tackling microbial infections, including resistant pathogens, and also is going to be useful in base solution for diagnosis, meaning that we are going to see more and more of the nanotechnology and artificial intelligence being used and being applied in sepsis in our years coming.
So thank you very much, Professor Jorge Hidalgo.